This panel is entitled Addressing the Future Payment Models in Patient Navigation, and I get to introduce my mentor, Karen Freund, who's going to be moderating this session. Many of you know Karen. She's one of the pioneers in patient navigation research. She's an established professor in medicine and was one of the PIs on the NCI Patient Navigation Research Program. She is here to lead us in our conversation, so I'm going to ask her to come on up.
Thank you so much, Tracy. You know, I am the proud mentor of Tracy. You know, they say, you know what a good mentor is. A good mentor is somebody whose mentees actually succeed you and do much greater work than you and really overpass you. So I'm just going to say, I guess I've been a pretty good mentor. So this is really a delight. When we envisioned this panel, you know, the question that kept coming up time and time again is, how are we going to pay for this? How are we going to pay for navigators? How are we going to develop sustainable models for navigation services? And so the panel we brought together are individuals who have figured out ways to do this that are beyond bake sales and foundation grants. I know that if I ask this group, how many of you have written a grant to pay for navigation, or how many hours you have spent, you know, we've all been there, and we know that that's not a sustainable model. Before I introduce the panel, I didn't know whether anybody had a chance to fill out the table cards, or whether anybody had a priori some questions they want to make sure that our panel answered, because I think that even sort of helps our panelists as they sort of provide their initial remarks. So before I introduce the panelists, I didn't know what, I wanted to sort of ask if there are any questions out there you want to all make sure that we address in this session. We'll have plenty of time for discussion afterwards as well. Well, we'll get started, and I'm sure this will generate questions. So let me introduce the panel. I'll start with Kim Bell. Kim is Senior Administrator for Cancer Services at Cleveland Clinic Health System, and she is responsible for strategic development, business management, and standard quality practices of their cancer service line, which includes their main campus, 10 regional sites, and 2 national practices. So she's somebody who's living and working with this day after day, figuring out how she's going to provide that care. Mike Flicker, who's sitting next to her, serves as the Director of Colorectal Cancer Screening for the Minnesota Department of Public Health. He's responsible for their health systems change and for direct patient screening under the CDC award. He's worked in collaboration with the Breast and Cancer Screening Program. He's facilitated partnerships with health systems, healthcare plans, the Coalition, the American Cancer Society, community health workers. And one of his current projects includes developing partnerships with international medical graduates embedded with clinical partner clinics to build a navigation program with common cultural awareness of the patient care that they serve. Then next is Heather Sheaffer. And Heather serves as Director of Patient and Family Services for the Abramson Cancer Center at Penn Medicine. She assumed leadership for this department in 2012, developing and implementing roles of oncology nurse navigators and oncology social workers. So she oversees Penn Medicine, their integrated oncology program. And then we all already met this morning Ron Kline, pediatric hematologist oncologist who has been working with the Centers for Medicare and Medicaid Innovation, the CMMI. So if we get a round of applause for our panel. And so I've asked them each to start with some opening remarks and just give you a sense of what they're working on right now with the common theme of what are the models of payment and how are you making the case for payment of navigation within your systems?
I guess I picked the wrong chair. I'm Kim Bell, and I work at the Cleveland Clinic, and my mentor for navigation is Dr. Freeman. So it's been an interesting journey there. So the Cancer Center started out I've worked at the clinic for about 32 years, and we started out 30 years ago with the Cancer Center developing it and having the clinical nurse coordinators as what we call today patient navigators, right? So I think it's important for me to tell you where we're at today in order to talk about the funding models. So, so clinical nurse coordinators, i.e. whatever you want to call them, if they're patient navigators, along with social workers, all navigate the patients through the acute care episode, through cancer or transplant. And Dr. Freeman and I were just talking about how hard it is these days to navigate patients. I'm navigating my family through the healthcare systems. It's very hard. So, you know, the nurse navigators or the clinical coordinators, as we call them, are extremely important to help patients move through their journey. Today we have about 70 nurse navigators, or we call them nurse coordinators, and we have 30 social workers. And to tie that into Dr. Kline's work is because of the oncology care model, and I'll talk about that a little bit later, we were able to add these type of navigators into our regional practices. So we'll talk about that payment methodology later. So the next phase of our navigation came probably in 2007, 2008, when I actually started learning about the disparities within our community. We had a community outreach program, but it was more event focused. So Cuyahoga County has higher than national mortality and late stage disease presentation. So I went online and started searching around and found Dr. Freeman and visited with him a few times and then applied for one of his grants so that I could start creating my navigation program for the community. Today, we've branched out to not only the African American community, but the Hispanic community, the Asian community, and the LGBT recently, because if you're not aware of this, if you look at some ASCO presentations, there's a huge disparities in care for LGBT community. So we've now hired and put navigators around these entities to help these people get in and get treated, get their screenings, to improve their overall outcomes. The third journey of ours was something that we call finance navigators, which is not the same as what you've heard out in the community. It's not hooking people up with their insurances, but what it is they work with every new patient that's going to get treatment at our centers, and they will talk about the cost of care. And we've been able to find the copay assistant drug replacement, as well as philanthropic dollars, as well as other foundations that will help support these patients, but also help support the organization with the financial disparities that they are not going to be able to make up because of some of the self-pay issues. So we currently have, we currently have 7 finance navigators that are spread throughout the health system, and this is just cancer. And then the last one is kind of interesting, and it's something that we created. They're called time to treat navigators, kind of time to treat liaisons. So my director, Dr. Brian Bowell, redesigned our care model, and he created what's called cancer programming. We created 12 disease-focused programs. Within those programs, they all received a lay time to treat navigator, and their roles are to look at every new patient coming into that program to say, what's causing the delays? Are the surgeries being scheduled 6-8 weeks out when it should have been scheduled 3 weeks ago, or 6 months out? What's happening there? Are CT scans being scheduled 7 weeks out when it should be, in a week? So these folks work with this disease-based program. They come together as a multidisciplinary team, and they've impacted time to treat on our patients tremendously, and I'll talk about some of those metrics. This is new for us. They've been in place for about 2 years now, and we have seen a decrease in time to treat. National is around 40 to 46 days, and we're now at 26 days for time to treat. It varies within each program, obviously, because there's certain things that have to happen within each disease group. But we're showing, really good metrics to say. And I want to say, too, these are all lay navigators except for the clinical nurse coordinators. So I think that's important to stress as well. So when I first started, especially my community outreach program, I kind of had to fly under the radar, right? Because everybody's like, you're going to bring in no pays to the organization. It's going to be horrible. Well, that isn't what happened. And so we, based upon Dr. Friedman's feedback, right away when we started our program, we started a database. So I have a database that's probably 12 or 13 years old, showing the ROI of helping the patients within the community, right? You can even think about what's the cost of somebody presenting with late-stage disease versus somebody that gets a screening and might have a polyp removed and not have colon cancer. So these are some of the ways in which, when you talk about financing these individuals or these FTEs, we are in a business, but we're in a patient care business. We have to show that we can support ourselves in the care we deliver. And so I have been able to demonstrate that with, and I know I'm long, sorry, but this is my baby. But we have to be able to demonstrate that so that we can continue to provide these services. And then when I look at my finance navigators, they actually brought in $5 million this year for the organization just for drug replacement. They brought in $2 million for direct patient assistance to help patients out. We're able to pay from philanthropic funds, because we go out and search for these, for things like utilities, roof repair, house repairs. So we're showing the ROI, which is very helpful, and we're showing improved quality. And so that also helps, because if you can show that, you can put them up on your operational budget, right? But with the decreasing reimbursement in healthcare, this is where we tie into the OCM. If we can work with payers to say, we need this per member per month to continue this type of work, to continue value-based care, to continue improving quality at a decreased cost, we need that type of structure. Okay. Sorry.
Very good.
We'll let everybody present, and then we'll start the discussion.
Great. Good afternoon. I'll put it here. Is that okay? Good afternoon. Thank you for the opportunity to be on this panel. I also want to pass on a special thank you from our family cat. Our family cat realizes that when I go to an out-of-town conference, I'm gone for at least one day, and the social order in the family changes significantly. The cat is on my chair, the cat is on my space. So as I go back, if I arrive on time, the cat will say, "Oh, you're back already," without even saying it. I've also learned that the cat can Skype. But so as we get to the Q&A, there's 4 specific areas that I'd like to talk about. If you do want to talk about the cat, I can talk about the cat too. But we'll really focus on 4 specific areas. Again, the timing in this is really important, because in my role at the health department, we're on some initiatives right now where we're having some success, but we're kind of on the cusp of even greater success. We're on the cusp of better measures and of new funding sources. And so these collaborations and these conversations are really important. So after this conversation, if anybody really wants to get into the weeds with any of the staff that I coordinate, please reach out and do that. We want this to be the start of a conversation, the start of data sharing on this path. The first general topic I want to talk about is the continuum of patient navigation activities that we provide. Minnesota is somewhat unique in that one of the activities we sponsored was Medicaid payment on a CPT code for CHWs. And I know that that's mentioned a couple times in the draft document that's out there. It's a fascinating concept. It's being underutilized, and for a whole host of reasons that we can cover later. It's being underutilized, CHWs, for billing Medicaid for educational purposes. We've provided grants to sites. Okay, we have a call center to provide telephone navigation. But the one that's got us really energized, the navigation intervention that has us the most excited, is the one that employs international medical graduates, or IMGs. The acronym is IMGs. And what we've learned is that IMGs are hiding in plain sight. individuals who were practicing physicians in their country of origin who are now living in Minnesota and across the US by the hundreds and are being underutilized in terms of their medical skills. So our navigation team right now, in addition to the telephone and the traditional navigators we have 7 IMGs who are embedded in clinics and team-based care. They're providing education and motivation for people to be screened. And I want to call out Abdi Haji as one of our navigators. Again, thank you, Haji. Please reach out and visit with him. He is one of a team that makes this happen. And it happens not so much because of native language skills, but because of cultural awareness. It's because of passion. So that's one of the navigation. That has spurred a cost effectiveness report. We're collaborating with the CDC and with RTI to hopefully publish the work that we're doing. We're in that cost effectiveness realm. And that has led to two Medicaid managed care organizations reaching out to us, offering us money to expand our navigation to include diabetes. Now imagine that. So we have embedded navigators familiar with the community saying, we just want a piece of that action to focus on diabetic care and diabetic management since you have that trusting relationship in cancer. Wow, that changes the cost effectiveness measure. That changes the metrics. That has led us to the final topic that I hope we spend more time about, which is risk stratification. Because even though there are 200 IMGs in Minnesota, that's not enough to fund all of and navigate all the patients. So how do we strategically and thoughtfully and effectively use these scarce resources to provide navigation across all 87 counties of Minnesota? And that's where the stratification models really come into play. So some of our partners have stratification models looking at acuity. We have FQHCs that are in primary care that have stratification models based solely on social determinants. So we're in both spaces. We're in the acuity model and we're in the social determinants model. We're trying to deploy our navigators to have a sustainable model to do that. So I've done enough teasing on there. I can hand the microphone off. Again, any of those 4 areas around stratification or around cost effectiveness, patient navigation, or CAT questions. All are welcome. Thank you.
Hi everyone, I'm Heather Sheaffer. I'm the Director of Patient and Family Services for the Abramson Cancer Center. I had a very short drive here, fortunately, from Philadelphia. And I also wanted to thank everyone for my opportunity to participate today. And also wanted to say that it got me out of taking my dog to the vet to have stitches removed, which went well, but I was very glad actually to be off the hook for that this morning. So I'm hoping to share a little bit of my experience as a leader and a founder of a nurse navigation program. As was mentioned in my intro, about 6 years ago, I was hired as the Director of Patient and Family Services for the Cancer Center with the goal of picking up after the entire department was fired, including my predecessor, with the idea that we would establish navigation for the first time as well as oncology social work. So it's interesting that we'd been a cancer center for many, many years, but actually had neither of those roles functioning within any of our locations. So I am a social worker by training, so the social work piece, I thought, I can't screw that up too badly. But when it came to navigation, I really wasn't entirely sure what that was, but I knew from my experience growing up in rural Pennsylvania in Appalachia that I looked around and saw people that I grew up with, including my grandparents, as folks who didn't have access to health care, didn't know where to go, didn't know what questions to ask. So that was something I wanted to bring to the role. I also worked in the Penn system before I took this current position, and I knew I couldn't figure out how the heck to refer my patients over to the cancer center to start treatment. And I knew patients needed a touch point, so as they went through treatment, they needed somebody that they could reach out to ask questions to that was a bit outside of the medical team. We find many of our patients will call and ask the navigator the dumb question that they don't want to ask of their provider. And finally, we wanted to build a navigation model that was around empowerment, and someone had mentioned that earlier today. And as a social worker, that's something that's really important to me. So we started this with 4 nurses. We were all hired on the same day. We started together, and we were assigned disease-specific locations. During that first year, we spent a lot of time just figuring out what we were doing, what we were calling what we were doing, so coming up with common terminology, common language, and collecting a ton of data. I developed an 80-point spreadsheet, which I'm embarrassed to say out loud, and I was really very unpopular for a long time, that the navigators actually hand wrote what they were doing day to day. That clearly was not a sustainable model. So fortunately, I was connected with someone in our Center for Innovation, and we developed our own productivity app. And we've updated it a couple times. We work with a company in Texas, and it's something that's kind of readily available. We just built onto that platform. So now the navigators just have to touch about 5 spots on a screen, and there's all of our productivity information. So at the end of that first year, going into the second year, we knew we had to justify the positions that we had. We knew we had a ton of data, and we just didn't know what to do with that. So we got in touch with our strategic decision support team and said, you know, how do we tell a meaningful story about what navigation is, and how do we prove our return on investment for navigation? We had many meetings, the 3 of us. We made it way too complicated, which I'm a social worker, my boss is a social worker. We're pretty good at looking at every angle of everything. And in the end, we decided to do something that was really simplistic, but has been incredibly powerful. We pulled registry data for a year, and we said, let's look at all the patients who are navigated, all of those who aren't navigated. Let's see what the difference is. And we were shocked that first year what we found, and we've been shocked every year since then. And we decided to focus on just 2 of the pieces of data that came back from that information. We found out our out-migration was 10% decreased if the patient worked with a navigator, and we found out that if they were navigated, they brought thousands and thousands and thousands of dollars to the organization that our unnavigated patients didn't. And I work in an organization where those financial pieces are really, really important. When we look at it, actually we just looked at it quite recently. So in this past year, we actually, when we looked at navigated versus non-navigated patients, the navigated patients brought more money to the system that would have covered every patient service that we had anywhere within our 6 hospitals. So it's been incredibly successful. So that's my very brief story.
Thanks, everyone. So I get to try to figure out something new to say since I'm on my second panel. I'll go ahead and continue with the pet analogy. In my home right now is 1 dog and 7 cats. I always tell people, be careful if you marry a woman or marry a person whose childhood goal was to open up a pet store. So we have 2 cats of our own and 5 kittens that my wife is fostering that were rescued from the wild. So I have pictures if any of you would like a 6-week-old kitten to take home. We can get you a very good price. They're all wonderfully nice kittens. It is generally a battle on my bed to claim my space so I can stretch out my legs between the dog and the 2 cats. Generally, I'm still the alpha male, most of the time, but not always. So with that, I'll go on to patient navigation. And I think that we have to sort of make a really clear distinction about the current world and the future world. And the current world is fee-for-service. And when you successfully navigate a patient and keep them out of the ER, you've done the right thing for the patient, you've done the right thing for the world, and you've done the wrong thing for the hospital system, at least in the current fee-for-service world. Now, that's overly simplistic, and I'll get back to that in a second. I think in the future world of bundled payment, when you keep a patient out of the ER, when you keep a patient out of the hospital, when you keep a patient at home for whatever reason, end of life care, you've done the right thing for the patient, you've done the right thing for the healthcare system, you've also done the right thing financially for your system. So I think those are 2 worlds, and I want to underscore that difference, because I think as we have this conversation, it's going to be really easy to confuse issues and really understand there's a place we are now and there's a place we are in the future, and we have to be careful when we talk about things, which world we're talking about. And again, it's really hard to have your feet in 2 canoes without falling in the water, and I think that's what we're all struggling with. Lisa Kennedy Sheldon put together a really nice navigation workshop for the National Cancer Policy Forum. And one of the folks, so talking about the fee-for-service system. So one of the folks who spoke was Cindy Cantrill from Sutter Health, who pointed out, and Sutter Health is located in Northern California, so right near UC San Francisco, right near Stanford, and found the same results basically that Penn did, which was that when they had navigation, care navigation, their out-migration, what some people inarticulately refer to as leakage, decreased a great deal. And so if you're in a competitive health, and I think her direct quote, because I just watched her speak again, watched the video again, she pretty much said, if we have a woman with breast cancer and we're not talking to them within a couple of days of them receiving their diagnosis, they're gone. I think that's a direct quote from her. They're at Stanford, they're at UCSF, they're lost to our healthcare system, which she quantified as being roughly $125,000 per patient in terms of lost revenue to the system. So that would be, a navigator, probably one patient, 1.5 patients, depending on how else you pay them. In the Bay Area, you get paid more with benefits. That you can get an ROI, if you will, from your patients, even in a fee-for-service world. So I think there's a strong case to be made for care navigation in the fee-for-service world. And again, I think I mentioned before, we're writing a paper on that hopefully will get submitted end of January on basically what we call the business case for navigation. So in OCM, we want care navigation to be something that you want to do, not something that you have to do. In the future world that I think is coming. So again, I'm not here to make news. I'm sort of the part of the totem pole that's buried in the ground at CMS. But I mean, if you look at the models that have come out of CMMI in the last 6 or 7 years, the majority of them, I don't know what percent, are bundle payments. And why is that? Well, because when you have fee-for-service and you pay things on a per-piece basis, you're going to get more pieces. So, sometimes they're necessary, sometimes they're not. And so how do you get around that? And how do you make the system less complicated? Well, as Dr. Partridge said, you create a bundle payment that says, here's how much we're going to pay you. We're going to risk adjust it, we're going to do all the things we can do, but here's how much we're going to pay you. And, if you're going to do, 5 PET scans in a year, God bless you. But the bundle payment's going to be the bundle payment. And if you do less, then you'll do better. And so I think that is sort of a paradigm shift in American medicine, where we sort of said fee-for-service is sort of unsustainable. And I'm not speaking officially now. I'm taking my hat off, my CMS hat off. I got to be careful here. But what you see happening are bundle payments coming through the system. And in a bundle payment world, you can accrue the value of avoided costs by doing the right thing for the patient, by doing all of those things. So I think that's sort of where OCM is, what oncology care model is. Just to reiterate what I said earlier, the oncology care model is sort of a transition between a fee-for-service world and a bundle payment world. If we went to oncologists across the country and said, okay, forget fee-for-service, we're just going to pay you a bundle for your patients, they would have run for the hills. So what we did was create sort of a transitional world. We said, all right, we're going to pay you a fee for service, and retrospectively, we're going to give you performance-based payments. So we're sort of going to create that value incentives of a bundle payment system, but make it a little bit easy for you by still doing something you're familiar with, which is fee for service. So, and I think certainly in a bundle payment world, care navigation is a slam dunk. And again, it's aligning incentives so that things work properly. It's the right thing for the patient. It's the right thing for the healthcare system. It's the right thing. It's the right thing for the U.S. healthcare system. It's the right thing for the hospital. It's a matter of aligning incentives appropriately. So I think that's where payment models are going. And again, I strongly agree with Dr. Partridge, having lived through managed care my whole career, where I've spent many hours arguing with people 3 time zones away about why this patient needed this thing today. I much prefer, again, me speaking personally as a physician, I much prefer a world where somebody gives me a fair compensation, fair value for taking care of a patient, and lets me figure out for that patient what the right thing is to do. And I think that's really a better world. And again, in oncology, so diverse. What you're going to do for a 50-year-old is something different than what you're going to do for a 90-year-old. And I'd much rather make that decision. I'm going to share with you just in closing, I always think God works in mysterious ways sometimes. I was the director of the pediatric bone marrow transplant program at the University of Louisville many years ago. And a young girl came from Mexico to get a bone marrow transplant with us in Kentucky. Now, how she found her way from Mexico to Louisville, I have absolutely no idea. But her family was paying for the cost. They're Mexican citizens, and they were paying for the cost of this bone marrow transplant for this child out of their own pocket to try to save her life. And all of us attendings, residents, fellows, we were all aware that this was a situation. And we worked very, very hard to skimp and save everywhere we could, knowing that every dollar we spent was a dollar that we were asking this family to pay. And we were able to care for her, do a good job caring for her in what we, in present terms, refer to as a high-value way. So, again, I always take that unique experience I had, and I say, and I bring it forward 25 years, and I say, yes, there are opportunities for us to provide more high-value care for patients and still provide good care for patients.
Well, thank you all so much. So I'm going to take the prerogative as the moderator to ask a question of each of the panelists before I open it up. And Heather, I'm going to start with you. So it sounds from your description that you came into a program where there was an executive decision to use operational funds for navigation. And so I guess my question for you is, what information do you need to provide to senior administrators, and who are those senior administrators you have to provide that to in order to maintain the navigators you have or to grow your program if you think you need more navigators?
It's really those two pieces. It's really those two pieces that I mentioned. We provide out-migration data, looking historically, and by disease site, and then also the ROI of the navigator based on disease site as well. And I forgot to complete.
ROI.
So the return, the return on investment.
So
yeah,
one is the
it's really the contribution margin of the patients within a particular disease site. And I completely forgot to say, now I'm thinking about my dog, that in the time, once we kind of figured out what our metrics were and we put out our first analysis, we were able to more than double our program. So we went from 4 nurses to 8, from 1 navigator to 6. We added additional social work resources and things as well.
And can you just describe what a contribution margin is, since not everybody lives in sort of the financial world of how hospitals
I mean, is there
think
someone
about...
who could probably do a better job of explaining?
No, I don't know. I'm waiting for the explanation.
So the contribution margin is the specific amount of money that particular patient brings overall. So we took a look at patients who didn't just come for, say, 1 doctor's appointment, but patients who then ultimately ended up getting treated within our system. So what was that sort of bottom line net amount of resources that particular patient brought to the system? So that's their contribution margin.
So it's the difference between how much you were paid versus how much the estimated cost of care was.
Exactly.
That the patient brought in.
Yes, yes.
So the next question I want to ask is of Kim. So you talked about having both nurse navigators or nurse coordinators and lay navigators. Mm-hmm. And so the 2 questions I had are the nurse coordinators, were those positions already in your system that you've now added added additional training and skill and sort of scope of practice, or were these new nurse hires? And then my other question for you is for the lay navigators, were they already in the system, or did you have to make the business case to hire those individuals? And again, what's the business case? Who do you have to go to have that put into operational funds?
Mm-hmm. So the nurse coordinators or nurse navigators, over the years, so I was one myself, I'm a nurse by background, and we have added based upon volume, right? So this is integrated, it was integrated in our model when we started delivering cancer care, because we knew it's hard to navigate the system and to get patients feeling comfortable coming in for their scans and things of that nature. So the organization has always accepted that cancer patients needed, not all disease specialties have these nurse coordinators. So the volume goes up, you add based upon that volume. And that's always been within the operational budget. And we have increased over the years, so, but I've been there forever, so, you know, I added them over the years. As it relates to the lay navigators, you know, it did start off with philanthropic funds. It did start off with, and I don't think that's a bad thing, and I don't think you give up your bake sales, and I don't think you give up your philanthropic funds, and I don't think you give up your grants, and you don't give up research. You have to have multiple ways to pay for everything right now in healthcare. So, you know, don't give any of that up. You got to figure out how you're going to support what you need to take care of those patients. And it's not going to be through the contribution margin anymore. It's going to be a multitude of ways. So, so we added based upon that. And so we did some granting, and then I put it on philanthropic funds. And then I, you know, kind of slid them into the budget, the operation budget over the years. And now that we have data to show the quality, and never forget showing the quality. Show the ROI, show the finances, but you got to show your quality too, because it's not all about the ROI. You're going to have patients that come in that can't afford care, and you need to take care of them. But if you're showing that you have an ROI, the organization is more forgiving, right? And so you got to have all of that in your business case. So currently today, my community navigators are all off of operations, and so are the which wasn't the case in the beginning. And so are the time and treat navigators. And the finance navigators are too. Now, not to say, when I need a new one, I slip it under philanthropic funds. And then when nobody's looking, I put it on operations. So don't televise this and show. But, you know, there's ways to do it. But you're making your you know, you have to make the margin to do the mission. That, I know it's an old cliche, but you got to do it so that you can help patients.
So my question for Mike, can you explain a little bit more the payment model for the community health workers for navigation with the Department of Public Health in Minnesota?
Sure. So the legislation was passed a couple of years ago after much heavy lifting from other people at MDH who were there even before I got there. And the focus is on education, and the focus is around 3 CPT codes in particular for CHWs who are certified. And it's been somewhat disappointing because literally at the 11th hour, there was a provision put in that for FQHCs who are in Minnesota, one of the earliest and largest employers of CHWs, it was rolled into the bundled payment, which means that even though Medicaid would pay the CPT codes, and even though the CHWs that qualified to earn the payment were embedded in the clinics and doing the work, the FQHCs couldn't bill for it. So right from the start, there was kind of a disappointment that we could not reach the full level of that. Does that answer the question? I want to make sure. I want to add one more.
So if you're not an FQHC, are there other practices that could make use of those codes then?
Yes, and there are. And after this, I can share some of the data that I think we're ready to share now from the claims. And there are systems that are doing it, but what's happening is. Some systems don't want to limit their hiring to CHWs who have the certificate because they want to utilize lay navigators or other navigators who maybe don't have the certificate. We have a large Native American population across Minnesota, and in those communities they use CHRs, community health representatives. And so that group of navigators under the CHW, again, don't qualify for the Medicaid reimbursement. So what winds up happening is the work is getting done. It's effective work and it's cost effective, but Medicaid isn't obligated to pay for it because it doesn't meet the strict criteria. And the other piece of it is Medicaid reimbursement is just too low. So it doesn't, there's no contribution margin on this. The reimbursement isn't cost plus enough to make it worth the billing. It cuts the losses. And so the most sites make the administrative decision that they would rather donate the CHW time than go through the administrative hassle of bill it to get cents on the dollar from Medicaid. So if we had more reimbursement available through Medicaid, then I think the CHW would get reimbursed more.
I didn't understand. You said when the bundle payment happens, the Medicaid payments no longer. Can you clarify?
Oh, sure. So the mechanism for FQHCs to get paid in Minnesota is a bundled per visit payment. It's kind of a wrap around payment that covers any level of visit, as well as some minor labs that are in that bundle. And a determination was made 11th hour that navigation and CHW work is included in that bundle payment. So even if the FQHC were to bill those CPT codes to Medicaid, the claim is denied, which is just unfortunate. Does that clarify it? Yeah.
Yep.
Yep. It's not an allowable CPT code.
So I'm going to ask one more question of Ron, and then I'm going to open it up if that's okay. So my question for you, Ron.
I thought Ron was
Hospitals and primary care physicians have been working under the Medicare ACO for a number of years now, and I'll give our experience, and I'd be interested in your reflection. So we started the same thing. It's like, here's where we are now, and if you can save money, then you share with Medicare in the savings. So the first year we did great. But the second year, now everybody's done great, so now everybody's at a lower cost. And so now, in order for us to make any savings, we have to actually even reduce our costs more. And so this year, we're actually, and since we're at risk, we're actually looking at actually having to pay back money to Medicare, because even though we've done better, and did better than we did 2 years ago, we're not doing as well as we did last year. And are there concerns amongst the oncology care model of that same concern that Medicare will keep cutting or keep lowering the bar in terms of where you're expected to provide value?
Sure. So I don't work on ACO, so
Yeah.
I'm not familiar with the details of it. We addressed that question specifically in OCM, where people said, well, we're going to lower our costs, and you're going to move the goalpost, and it's going to be harder and harder for us to get a PBP, performance-based payment, as we go forward. So in OCM, we specifically don't do that. So your historical baseline is based on your costs, practice adjusted, case mix adjusted costs from, I think, 2012 to 2014. And then the only thing we do with that baseline is we trend it forward based on costs for specific oncology patients outside of OCM. So, if a 70-year-old male lung cancer patient who hasn't had surgery and has received radiation therapy went up by 9% outside of OCM, then it goes up by 9%. We trended forward 9% within OCM for that specific patient. So specifically in OCM, if I don't want to make sure I don't talk in a circle, we don't move the goalposts. The historical benchmark was set 2012 to 2014. We trended forward based on medical inflation, based on what's happening outside of OCM, and a novel therapy adjustment for new drugs, and that's what we do. So we have not moved the goalposts within OCM.
Great. All right, opening it up, and I think
I didn't say, the last thing I meant to say early on is I'm really proud to say that two OCM practices are here on the panel. We have Cleveland Clinic, and in Penn Medicine we have Lancaster General Health. So they're some of our favorite practices. So
So Gabriella, we've already got 2 of the 175 right here.
And you have Michigan, and you just lock the doors and get,
Great. So I think we're going to start with Linda. Oh, I'm sorry. Sorry, Linda.
Hi, Lena Janda from the Icahn School of Medicine at Mount Sinai. We've been looking at both outward migration, but kind of struggling with how is anybody measuring inward migration? So if you keep a person in, does he or she bring in other people?
As a doctor, I'll say, I guess it depends how well you treat them. I think the larger issue, and I think that there are enormous benefits to taking good care of patients that we haven't measured, and whether it's decreasing out migration, whether it's increased use of ancillary services within your healthcare system, or to your point that I've never actually heard anybody make, I think it's really interesting, is do you then get friends and family? Because the word of mouth goes out, hey, they treated me really well there.
So so one of the things we have to look at is our race distribution, right, for Case Comprehensive Cancer Center and things like that. And I particularly pay attention to that, and also through our tumor registry, because to your point, I'm right. I have multiple different races I'm focusing on, but right around the Cleveland Clinic, it's a lot of African Americans. So I look at my success as, am I bringing more of those individuals into the cancer center? And so I look at that year over year, and I compare what I get from the data from CASE, and then I look at the data that I get from our registry, just to make sure, am I growing that? It's really, things like for navigation are difficult to measure.
Just real quick, I don't know that now, but I might a year from now. And the reason I might know that is because of the Medicaid partnerships. So one of the metrics they're looking at, so in all of our relationships, we only want one or two metrics. It might be a different metric with each of our partners, but we'll only want one or two metric. And on the health plan side, they're looking at people who have enrolled in Medicaid who have not established a PCP, who have no primary care clinic. So when they're sharing their data with us, which is unprecedented for the Medicaid plans to share their enrollment data with the health department for the purpose of navigation, how many of people who hadn't established a PCP now have? I don't know what that's going to look like, but that could really be powerful. Maybe it'll impact their diabetes scores. We hope it'll impact their cancer scores. We feel like cancer screening is the most powerful door to open to recruit people for a PCP. But we may know that data a year from now. I hope we do.
I want to clarify, I'm very pleased that you're working with Indigenous people in Minnesota, but I want to caution you about using CHRs, our community health representatives. Community health representatives are basically trained to handle transportation to and from clinical settings, and they basically have no training in cancer or any type of navigation. They have been very frightened about how they've answered questions. They call our hotline and tell us what they've told patients who are on their bus going back and forth to the clinics. And they need special programs. And I don't know if you have things that are offered there. Mayo Clinic does run their navigation programs through Spirit of Eagles. And there is training that's available for those navigators or CHRs, community health representatives. But it's a disaster about to happen. And so I encourage you to try to help them get into training so that they do continue doing a good job, because CHRs are not navigators.
That's a very good point. It gives me a chance just for 1 minute to throw out a recognition for our key partners. So we're located in St. Paul, and Minneapolis is the hub for the American Indian Cancer Foundation, ACAF, and we partner with ACAF. So we're sort of a pass-through organization. As we get CDC funds or Komen funds or funds from the Colon Cancer Coalition, we partner closely with the American Indian Cancer Foundation, and they work in local communities and IHB, or Indian Health Services, to identify CHRs and distribute the funds and to get metrics that meet the funders' needs. But that's a very good point.
Thank you. And they do a nice job with the CHRs.
ACAF? Oh, they're wonderful. Yes, they do. They're wonderful.
Linda?
Yes, hi. Ron, I think this question might be for you. I think as we're making this transition to bundled payments, and you have examples of that where navigation is being built in, do you see, though, a different set of ROI that will be required to support navigation moving forward if it's a bundled payment? And now, in a sense, are we competing with other programs within that health system in a different way than maybe we are in the fee-for-service? I'm just curious. I'm not as familiar with all the issues around bundled payments, but it just raised for me a question. Might we need to be thinking about different ROI we need to look at in the future?
No, absolutely. I mean, I think the ROI is completely different in fee-for-service than it is in a bundled payment system. In a fee-for-service world, it's decreasing out migration, it's increasing use of your ancillary services, maybe it's friends and family who now come to your healthcare system. Again, without any moral judgment, in a fee-for-service world, keeping somebody out of the ER is a net negative financially for the healthcare system. Keeping somebody out of the hospital, keeping somebody ICU who has progressive cancer, those are net negatives, and that's just, I think, an objective reality. In a bundled payment world, keeping somebody out of the ER, keeping somebody out of the admission, not having somebody with progressive cancer die in an ICU. By the way, 27% of people with cancer die in an ICU, which I think is I was amazed when I saw that number. I think it's a horrendous number. It's not what you'd wish for your own family, or your own family members. So I think the ROI changes completely. It's a whole different set of world, which is exactly why it's so hard. I think as we make that transition to sort of figure out, how you do things, and maybe just do the right thing for the patient and let the money take care of itself.
Double-barrel microphones. Anybody else? Anybody? Okay.
Totally agree with what Ron just said. I was interested in you guys talking about in-migration, out-migration, something about bringing more money to the system, all related to volume, which is incredibly important in a business model under fee-for-service. It's all about volume. But under a bundle payment reform, it's going to be about quality and cost reduction. So you're not going to be marketing yourself in the traditional way that we do in a fee-for-service world where we want people to come to us. You're going to be marketing yourself on the basis of data that shows you're providing high-quality, cost-effective care in your hospital system or your network. The other thing that's is really amazing how dumb we can be in healthcare. I mean, really. So here's Ron up there, smart as he can be, working with Medicare, and he's doing alternative payment models. So he's got a model out there right now in oncology care where we reduce cost by redesigning our healthcare delivery system, and we share the return with him. We share in the return with him. In other words, we give him 4% before we get anything back. If I were a bold CEO of a health system, I would negotiate tomorrow for bundle payments in every disease I had, with them paying me the same amount that they paid last year, the baseline that Ron talked about for 2012, 2014. And then, instead of sharing the return with the payer, I actually get to reinvest it all in my healthcare delivery system to make it better and better. What Ron's doing is he set his baseline, and 5 years from now, we will have reduced costs by 15%, 20%, who knows. And when he delivers the bundle 5 years from now, it's going to be 20% below what it would have been if we'd negotiated a bundle yesterday. So it's incredible to me that I hear no discussion about that in hospital systems. That it's like, okay, it's coming, but what are we doing to get ready for it? Can we negotiate now where we'll have a bigger piece of the pie based on our increased risk-taking related to it? And it's just not happening. So at the highest fundamental level, $3 trillion in healthcare expenditures in the United States, $3 trillion. Conservative estimate is $1 trillion of it is unnecessary cost. $1 trillion is 1,000 billion. It would be 1,000 billion dollar bills stacked up here on this table. And so, that's way too much waste, obviously. But there's great opportunity there too. So if you got $1 trillion out there that you can redirect in your healthcare delivery system to provide quality and cost effectiveness, what a better world this would be. I mean, it's beyond my comprehension how hospital administrators today can't get on board looking at the future quickly, aggressively, and get this fee-for-service and volume out of their lexicon.
Yeah, so Ed, if we can give
people a chance to respond to that. I think also, since we have two systems here that have taken on the oncology care model, has that changed how you view return on investment?
No. So we have approached payers. We have huge experience with creating bundles in cancer. And we started creating them 5 years ago, but they can't administer them, and they're not interested in them. And so, or they haven't been. And so, because we continue to go back to payer after payer, it's really hard to administer a bundle because of the way in which the bills come across and the systems. We need to fix the systems, right? But right now, payers aren't ready for it. We've approached multiple times. Now, I'm hearing it's starting to bubble up again. We'll see what happens. But as it relates to OCM, and, you know, I don't know, did you talk about the per member per month that we get as well? So we get a per member per month, which also helps us supplement some of the decreased revenue, right? Because he's right. I am decreasing revenue for my organization, but it's the right thing to do because my patients aren't going to the ED. They're not getting readmitted and consequently getting some nosocomial infection and get sicker and end up in the. So all these are the right things to do, and we are in a dual system. So right at times, you know, we're in the fee for service, we're in the value-based care, and so we're teetering and we're doing both. But that per member per month has been extremely helpful in our ability to provide the navigators, the clinical coordinators, the social workers that do help decrease the cost of care. So I think that's one of the things that's really important to keep in mind. And I think we all need to keep trying on bundles because I agree, but it's about quality. I think it is still about volume though, but it is about the way in which you market because we're looking at best cost of care so that patients don't have high out-of-pockets and so the quality is better. And that is what OCM promotes and they monitor. Like, don't be skipping certain things that are quality-driven, driving for patients. If you do that, you know, they will be able to track that. So you have to make sure your quality is high and your expenses go low. The other thing is, and then I'll hand it off, but, you know, when we joined, it was a great match for us because we do continuous improvement all the time. We were building CarePass already. So what OCM was asking of us was in our strategic plan. And so we just kind of partnered along with them as we went through. So it's been, and that's what healthcare systems and oncologists need to do.
So I wanted to say, and I'll probably make your point, we have 6 hospitals within our system. One of the 6 has the OCM model, and it's not the one that I work at. So we are, you know, really balancing in more than one canoe. There's very little, I think, that's happening in our other 5 hospitals to get ready for when bundled payments come, except trying to keep patients out of the emergency department. That's someplace that we really focus our energy. But otherwise, I think we're still really focused and working in a fee-for-service model.
And I always tell people that if you're working in a fee-for-service model, your best case scenario is that you'll be the last iceberg to melt. That's really your best case scenario. And that has nothing to do with climate change. That's not a climate change comment. So I think, you know, I think we're actually past $3 trillion right now. I think we're at 3.2 or something like that. I think people don't know what $3 trillion is. So I always tell people, the U.S. healthcare system is bigger than the economy of France. So, you know, if you look at GDP, there's the U.S., there's China, there's Japan, there's Germany, and then there's the U.S. healthcare system. And after that is France, and then I think comes England. So that's how big our healthcare system is. And, you know, and I don't know how, I'm going to put this out there, and I have no idea how reflective this is of the truth or not. I'll just at least put it out there. I have a friend who's a former medical director at a large insurance company, and he could not get his insurance company interested in any kind of OCM work. And I said, why? And his answer was, basically they view the rising cost of drugs as basically trumping everything else. That they're not interested in saving, you know, 3 or 4% per year on an OCM type of thing when the cost of drugs is rising 10%. Again, that's one person saying that, but, you know, I sort of put that out there. And then, and Ed, since I'm a northerner, not a polite southerner, I'm just going to tweak you slightly and say that if UAB wants to assume two-sided risk, then the CMS cut will go down to 2.5%. So you just have to belly up the bar and say you're going to take two-sided risk.
Hard to follow that. I just want to add quickly two things. So right now, as the Department of Health, we are in both canoes. We are in a fee-for-service world with our partners where we can show metrics that no-show rates are 2% if you have a navigator. That has a positive ROI, and that works in the fee-for-service world. 2% no-show rates at an endoscopy center is phenomenal. That's a definite ROI. There's another secret sauce, though, that's going on here. It's more than patient navigation. It's the spirit of collaboration. So we have two partners that are large ACO models in the Minneapolis-St. Paul area, and they're responsible for a panel of 45,000 people in this ACO model. They've assumed risk, and they're realizing that the way to appropriately match resources with patient need is with collaboration, because our communities are so diverse and there's so many points of entry in the healthcare system that they've reached out to us and say, okay, out of these 40,000 people, we need assistance with 1,500 people living in this community to connect them with a PCP or to have them not go to the emergency room. So yes, it's an embedded, or yes, it is an ACO model, they're bearing risk, but the tools and the people to enable them to reach their ACO goals requires more than their internal resources. Even in the large integrated systems, it takes collaboration with all sorts of organizations to help them reach their cost goals. So it's an odd space. I didn't think we'd be there that quick, but here we are with a small team of navigators helping one of the large ACO models keep people either establish a PCP or not go to the emergency room. It was a wonderful surprise. And I want to share this data, so after this event, please reach out and connect.
Okay, Crystal, while I'm heading over there, just a quick question for those of you who've shared or have results, other than academic journals and the like, because we've talked a lot about dissemination of results and information. For the information that you do have around cost and analysis, I mean, there's internal reports and data that you can share to help make decisions, but have you found any other specific dissemination channels that have been very effective in terms of changing people's policy and belief around navigation as it relates to cost and cost savings? Anything that's coming to mind? And then we'll have Crystal ask her question.
Social media, we do a lot of Twitter and tweets and Facebook and things of that nature, just to get the word out. And we will put our data results out there as well.
So you're using social media even for costs and even those sort of data elements? And you've seen effective, like, uptake of people being...
I think it's just another form of communication, right? Like I said, we're putting... Microphone! Oh, microphone. Usually people tell me I'm loud enough, but, you know, we're not tracking how that's impacting us, but it's a form of communicating out what we're doing and the results of what we're doing. As well, we have a white paper coming out with Genentech on the finance navigators, and so we plan on presenting like at NCCN and, like you said, the journals and things of that nature. But I don't Twitter other people, Twitter and social media and things like that too, just because people are really looking at that now, just to give them ideas and thoughts and things like that.
Okay, great. Crystal?
Sure. It's actually on a comment about what you all just said and kind of a question. But, you know, I guess from a hospital administrator point of view, not mine because I do have a clinical background, but from our hospital administrators in our hospitals, they are moving to a different mindset while they live in both worlds, both canoes, just like you said earlier. But we do have some barriers that, and I know you talked about collaboration, but, you know, we don't employ our physicians, so and that's just not our model. We want them to come to us, you know, for other reasons. So that's just not the model that we have. We have tons of bundle payments because we are HCA. We're required to do tons of bundle payments, and they're not just in cancer. Actually, there's barely any in cancer. Everything is in the things that have come down, cardiac, things like that. But the way that HCA's responded, we always respond with pilots. And trying different things in different places beyond what we're required to do with bundle payments is basically we pulled together a care management governance council for all service lines. because what we found was our administrators didn't understand the continuum of care either. You know, they didn't understand that it's surgeon, med-onc, rad-onc, you know, all the different components. So even thinking about a bundle payment and then understanding really the true complexity of cancer care, perinatal care, bariatric care, diabetes care, it covered so many areas that they really struggled to understand. So what they're doing is they're putting things into place using navigators, coordinators, technology tools, AI, all these different things, and trying to develop maybe not the cheapest or the most expensive, but the most consistent so that they can go to payers. Our other barrier has been, and I'd love to hear how other people have done that with when you don't have employed physicians, like how you've collaborated. The second thing is our, well, actually, I'll just stop there. So how have you all developed collaborative models when you have non-employed physicians that you work more in that community setting? That's where 82% of patients are taken care of. So how do we do that?
Especially when they have other EHR systems that don't talk to each other. I think that's one major gap in technology where we have to see collaboration.
And just a quick reminder while you're deliberating to please use the microphone.
That's the problem. But we are trying to figure it out. I mean, I know I don't know that anybody just has an answer, and I don't expect that. I mean, but trying to deliver consistency, and here's our other issue. Payers come to us because we are large and we have developed consistency, but then they steal my employees because they're the only ones that have developed that continuum in that way and understand how to reduce duplication, how to ensure productivity, how to measure standards. And so it's a difficult place. We want to be collaborative partners and share our information. And I think many of you in this room know that I share a lot at a lot of different groups, because I do believe, you know, sharing it'll raise all bars. You all compete with us, we compete with you, and the patient wins. And I always say that. But it is difficult when some don't share, or some take information and then go and build their own models through the insurance companies and things like that, that make it difficult to really keep the patient the center in mind.
So I want to give a thoughtful answer. I'm going to take off my hat as a public employee. In past lives, I used to do physician compensation modeling. And I'm going to do the thing that consultants do, is answer your question with a question, which is, what's the timeline? So if the timeline is 12 months, I think your collaborators are different than if you have 36 months or 60 months. Because moving physician compensation and alignment and incentives and what you reward your departments really is a function of how much time do you have.
Yeah, it's a marathon.
It's really, it's right. Yeah. And that's what we're seeing in the field, and that's a wonderful approach, because it's a large ship in the water, and if you realize it is the marathon, then all of a sudden you can strategically take one department or one area at a time and kind of fix that alignment. And again, the reality is we're probably never going to get there, right? It's just one more step on the continuum.
I was going to add and this is not my CMS hat, this is my private practice hat. I've found myself taking my hat off a lot. If physician compensation is based on fee for service, and you're in a value-based model, then you have two mechanisms at war with each other. So I think if you're going to go to a value model, you can't tell a doctor, we're going to pay you more for doing more.
I think I'm going to think of you as the cat in the hat whenever I think about you.
I'm trying so hard to keep my job. I really am.
I'm interested in knowing, how do you go about explaining to a patient the bundled model?
Me?
Yes, I am looking at you. Anyone can answer, though.
I mean, there's a benefit. I mean, there's a beneficiary notification letter that, you know, that goes on with being part of OCM that explains that they're in a model. It's always been a lot of fun, because initially in the explanation of benefits, the MEOS payment was part of the EOB. So we had Some patients calling up the Medicare fraud hotline saying, I never got no meals, this doctor's committing fraud. And then we had to sort of sort that out and take it off the system. And curiously, just sort of how people perceive things, in oncology care model, women who are on hormonal therapy are part of OCM as well. So you'd have women calling up saying, I'm not getting chemotherapy. What do you mean I'm in the OCM model? So just sort of different things in terms of the way people perceive it. I think, and I was going to say this before, so this is a great opportunity for me to say this. In a fee-for-service world, the financial incentive is there to do unnecessary care. And in a bundled payment world, the incentive is there to not provide necessary care. So you have perverse incentives on both sides. And one of the things we do in the oncology care model, as Kim was mentioning, besides just quality measures, which are unfortunately largely process measures at this point in time, we also are looking at outcomes. So we're looking at the Social Security death database. We're looking at machine learning to figure out relapse status. So we want to make sure that at the end of the day, when we report on how OCM is done, we can say to the world, patients in OCM did as well, or better, hopefully, than patients in fee-for-service at a lower cost. So, and I always tell people, if we were this lean, mean, in shape healthcare system, our job would be really, really hard because there'd be nothing to cut. And what are we going to do about that? And as Dr. Partridge mentioned, we estimate that 1/3 of healthcare dollars are wasted. So I always tell people, before you ever get to the point of cutting muscle and bone, you got a lot of fat to cut. So, I think the way, I don't deal with patients directly in OCM, but the way I would explain it is OCM incentivizes higher value care, patient-centered, higher value, high quality care, and that's really what we're trying to do.
You commented earlier about 27% of cancer patients dying in an ICU. The last data I had reviewed, I think, was from 2014. It was 24% then. Are incentives finally being incorporated into cancer care so that we can begin communication earlier about end of life rather than this nightmare at the finale, which still seems to be happening?
Well, in a total cost of care model, right, if the patient dies in the ICU, in the hospital, rather than at home with hospice care or good palliative care, there's increased cost there. And I would argue that's not good for anyone. And so I think to the extent that there's a financial incentive to prevent that total cost of care model is there. And I was going to add, I think about this a lot, as you might imagine, is, people say, well, what is high value care? And usually when people say, what is high value care, they wave their arms around a lot and they throw around a lot of buzzwords and, what did you say? And so when I think of high value care, I think of, how would I want one of my family members treated for cancer? And I think if you are treating your patients the way you'd want a family member treated, you're providing high value care.
Right, and OCM also looks at chemotherapy within so many days of death, and then hospice within
Yeah, I'm not sure we look at that.
days.
I think we thought about it. I'm not sure we look at that.
Well, we're looking at chemo within so many days of death, along with radiation.
it's
But you do
30 days.
hospice,
We do
for
hospice,
sure.
yes.
And I think, it's easy for all of us to sit here if we're not sitting in front of that patient. So we got to figure out, does that 27% of patients, are they pushing their physicians to say, no, I want all in? And so you have to be able to tease that out, because not all patients say, yep, nope, I want to stop. And so you do have to take that into consideration. So if we're going to speak about that, we got to tease out which ones are the patients that want to continue to try and have hope, and which ones do want to take care at home or in a hospice setting or things like that. Because it's a very difficult conversation to have, right? And I think people are having those conversations more. I think palliative medicine is much more prevalent in practices now. So I think we're getting there and we're changing culture. But, it's kind of, I never judge. I've sat in front of cancer patients when they're like, I want to go all the way, Kim, I want to go all the way. So think about being the physician making that decision, saying, oh, sorry, no, because our metric says this. So I think we have to take that into consideration as well.
I was just going to say real quickly, it's never going to be 0%, but it probably should be less than 27%.
Yes.
Yeah. So Lily, I think you bring up this really important issue, which is how much do any of us really know about what our insurance coverage is? And certainly once we get to Medicare, do patients know if they're on a managed care? Do they know if they're in an ACO? I mean, the Medicare ACO was set up where patients are just enrolled. They have no knowledge that they're in an ACO, what that means or what the implications are. So I think you're bringing up a really good point. As, you know, we're having a hard enough time navigating patients through the care, let alone providing the changing environment about how payments are made. But if patients don't know that, there are patient rights that I think that's an important issue that at some point we need to be addressing. In terms of, the one comment I wanted to make in terms of the end-of-life care issues, I don't see where bundle payments alone are really going to address that. I mean, there's very good data that patients who present late in their cancer care, and those oftentimes are patients who are underserved, that they are the ones that are more likely to have a more aggressive care at the end, but there are all kinds of challenges in terms of really education about what the care is about, and patients feeling that with care is being withheld when they present late and intensive care is not provided. So I think that there's more than just bundle payments, and it's really about getting all patients into care early. That's really going to have some impact on that intensive care at the end of life.
But it's also about people having that conversation. And I will share with you, I have certain hot button issues where my team looks at me and says, okay, Ron's going to go crazy on this one. One of the IOM care plan elements is that you discuss prognosis with patients. There are a few, just a handful of oncology care, of OCM practices that have said, we don't want to discuss prognosis with patients because it's going to take away their hope. And at that point, I generally go crazy. I say, my team sort of holds on to their, oh my God, Ron's going to go off. How can you not discuss prognosis with a competent adult? I mean, even if it's bad, you can always hold out hope, but I would want that for myself. I have a family to take care of. If I'm going to die in a year, then I need to know that. I think that, yes, there are different cultures that have less trust of the medical care system and view things as being withheld. So it's never going to go to zero. I think one of my favorite expressions in CMMI is that perfect is the enemy of good, because we're always having these conversations that this is not the whole answer to the problem. And you're right, it's not, but it's a start.
I think that we still need to do more in medical schools in teaching new physicians or people that are going to become new physicians how to have this kind of conversation. Because right now, I'm still seeing, as long as there's another drug available, then that's going to be the conversation between the doctor and the patient. When the patient may really want to stop. Where I am, I hold my nurse navigators accountable for understanding from the patient how far do they want to go, and do they really understand the risks and the benefits. Tom Smith has done beautiful evidence-based research to demonstrate that being honest with the patient regarding their prognosis does not take away hope. It actually helps move the patient through phases of hope so that they're not going to end up in an ICU. And we also need the families to understand, because the families will go behind their loved one's back, do an end run to the doctor and say, I know mom wants to stop, but we've talked her into doing one more drug if she loves us, which I just want to shake that family. Sometimes I do shake the family in saying this is her life, her choice. When you get your turn, you can have your choice, but don't do that. Please don't do that to your mother. But we do have to push for physicians to learn better communication skills and to not see this as a sign of failure when their patient dies, when we knew from the start that was going to happen.
All right. Is any other questions? Are we good? So Monica, are we set to close, or Karen?
Yeah, Karen, did you have any final thoughts?
Well,
Now that we
maybe
all
I'll
have
just,
mics.
since we are finishing a little bit early, but before we end, any final thoughts from any of the panel?
Said enough.
3 words, and none of them are cat. data, data, data. Data, data, data. It's there, it's mineable. We just have to have the creative energy to find it. That will substantiate our work that we do and validate it, and also keep it funded and effective for our patients.
I think. You know, I was kind of bummed we didn't hear from Kim or from Karen about their cats. Anything to share, ladies? Because the cat talk started, you know, to your right. So I just wanted to see anything to share.
2 labs, brother, sister, they're good, no cats.
Yeah, we got the cat sitter at home. I don't think I have to worry about my chair, but.
Okay, good. All right. So we're all there.
I just want to put a great shout out to this panel. I think this has really been a very informative discussion. I want to give also a shout out to Nina. The Commission on Cancer was really helpful in finding individuals who weren't in our sort of usual circles, really to think about some of the payment issues. So we want to thank you very much for that. Thanks for everybody.